Hello and welcome to another edition of COVID-19 Right Now from the Yale School of Public Health. I'm James Hamblin. I'm a lecturer here at the school, and I am lucky to be joined today by Robert Heimer. He's a professor of epidemiology of microbial diseases and of pharmacology, and we're going to be talking today about the intersection of COVID-19, substance use disorder, and criminal justice. And among possibly some of the other many things that Dr. Heimer has studied and written on over the course of a very accomplished career. And as always, if you have questions, please drop them in the comments and we will do our best to address them. Thank you so much for joining today, Dr. Heimer.
My pleasure.
I like to start by just asking guests what's at the top of your mind right now. It seems like things are changing day to day and hour to hour. There's new news and new things to consider. So what's on your mind right this moment?
Well, there are, I guess, three things which sort of intersect with each other. I'm not sure how you draw the Venn diagram of the intersection of these three things. But one thing is that it's quite clear that coronavirus is now, SARS-CoV-2 is now probably close to an endemic disease in the United States. We've allowed it to take root. We've allowed it to spread to the point that it will be with us for a long period of time. And to talk about a second wave coming in the fall or at some later date is in fact a preposterous assertion, because the first wave, we may have reached a plateau, but it looks like we're going up again. So if you want to think of this as the second wave, and in some ways socially it is, having instituted lockdowns and social distancing and control measures that we're relaxing, we're only going to see increasing cases that are, you can think of it as a continuation of the first wave. You can think of it as a beginning of a second wave, but it doesn't matter how you think of it. We're seeing 20,000 new diagnoses every day. We're seeing 1,000 deaths, many of them unnecessary, every day. We are seeing populations at highest risk continuing to be differentially infected and experiencing differential mortality. And that brings us to the second point, that among the groups of people who are most at risk and most disproportionately affected, in addition to the elderly, which everyone knows about, is the group of people who are substance users, who are not in treatment, who are either in the community and estranged from medical care and therefore diagnosed late and treated late, or the group of people who are incarcerated and, in such situations are at high risk for rampant transmission in carceral settings where it's very hard to create the social distance necessary to keep people from infecting each other. And all of that, of course, the third issue that folds into all of this is the renewed awareness, the heightened awareness of the historical racism, the historical prejudice that devalues the lives of Black and Hispanic individuals in this country. And that all of this together means that a lot of vigilance is going to be necessary on the part of public health people like myself and my colleagues to make sure that this three-way or this three-level, this group that's at risk on three different levels needs more attention, needs more care, needs more efforts to in the short run, and even in the long run, if this disease is truly endemic, to provide the necessary efforts to reach, to work with, to protect those populations. And we've tried to do that here in New Haven and statewide through our harm reduction working group. We've been very good at acting proactively to get the messages out to drug using communities, whether they're still actively using or whether they're in treatment for treatable medication-based treatments like for opiate use disorder, or if they're in abstinence-based treatments for the substance use disorders that we don't have medication-based treatments for, to make sure that their needs are, that service providers are aware of their needs, can attend to their needs, and can respond with information that's useful and meaningful.
I'd like to get more into the solutions in a bit, but when I want to back up just a second. So you laid out three things here that are in the front of your mind. You've been studying the intersection of infectious diseases and substance use disorder and criminal justice in ways that this is a new virus to us, but it is elucidating old patterns. It is elucidating some of the same disparities and issues that have been with us for a long time. It's just sort of putting a magnifying glass that, and some people are just realizing, as you see in some of the BLM protest marches and whatnot, that police violence is a public health issue, criminal justice reform is a public health issue. These things are all tied to the pandemic, and it's a moment of awakening. But for some people, but for you, this has been central to your work. Can you take us back through some other infectious diseases we've seen in the past that highlighted these same sorts of disparities among substance use, people with substance use disorder, and among people who are experiencing homelessness and issues with incarceration as well? Obviously, there are millions of examples there, but anything that kind of stands out in your mind?
Obviously, the paradigmatic example is HIV, AIDS, when it was first discovered in the early 1980s, was a disease that was concentrated in marginalized populations, one of which were people who were injecting drugs. And many of the first cases outside of the gay community were, in fact, among people with untreated substance use disorders. Some of the earliest work demonstrated quite effectively that getting people into treatment and keeping them in treatment for their opiate use disorder lowered the rates at which they would be injecting heroin and other drugs, or at least heroin and other opiates, and that was associated with a substantial decrease in HIV infections. We've known this for a long time. We've known this for 25 plus years. This is not new. It is, in fact, one of our public health successes, and something we can build on, is that we have reduced, where we have set our mind to it, HIV as a disease with high incidence in people who use drugs. And we've done this with a variety of approaches. I mentioned substance use treatment, medications with methadone and subsequently buprenorphine for opiate use disorder. Most notably, we've done this by expanding sterile syringe access through syringe exchange programs, syringe access programs, pharmacy sales, physician prescribing of syringes to drug users, all of which reduces the need for people to share infected syringes in a group of people and reduces transmission. Right. We've shown this to be the case, and I think most impressively in some ways is the work here in Connecticut. When I started doing this work 30 years ago, we were seeing 650, 700 new HIV diagnoses. Before the era of HIV diagnosis, even in the era of counting AIDS cases, we were seeing that many new AIDS diagnoses every year. The last 3 or 4 years in Connecticut, we've seen 20 or so new HIV infections in drug users. We've decreased incidence, if you will, by a factor of 30 or more. And that is an amazing public health success. It's not just clean needles, it's not just treatment, it's also, treatment for opiate use disorder. It's also that treatment for HIV with, the proper combinations of medications, antiretroviral medications, make people unable to transmit the virus even if they're infected. So we have lots of tools to control this virus. HIV, we have none of those tools now.
Right.
We don't have a vaccine, we don't have a drug treatment that reduces the titer in people's coughs and people's breaths when they're infected. We don't have a way to treat people once they become infected. The disease takes its course. And of course, if people have underlying health problems, that course can be more acute, more severe. And if they don't go for at least getting diagnosed, they can spend a lot of time transmitting before they become aware that they're infected. And this is a problem that's heightened in the communities of people who use substances because they tend to be estranged from the healthcare system. So it's really important for us to get out there into the community and preferentially test people who on their own would not be seeking testing.
So you've laid out myriad issues, which some scientific, technological issues, which will happen eventually. We will have forms of treatments and vaccines that are better than what we have now. And we were at a phase like this in the early days of HIV/AIDS, where we knew very little. We didn't have treatments. It took a long time to get to where we are right now. A lot of hard work, and you've surely learned lessons about how to mobilize the will, the political capital, the public sentiment in a way that's effective, and not have people start to take a disease for granted in the way that you see some people starting to do with the virus, and starting to reopen and go back to their normal lives despite the ongoing risk.
Well, what is remarkable is looking at the difference in some ways between the medical technical response to HIV in 1981 and to COVID, SARS-CoV-2 in 2019, 2020. It took 3 years to even be certain that AIDS was caused by a virus, although many people had their suspicions. Took that long to identify a virus, took 3 to 4 years to get diagnostic testing out in a way that we could identify people who were infected. But the same things happen so much more quickly now. Within a month, we knew, what the sequence of the virus was. We knew how to make tests to determine who was infected. The political response, however, has been in some ways, no different in this country. We have had regimes in place at the time that didn't, excuse my French, didn't give a shit about populations. It took President Reagan 6 or 7 years to even mention the word AIDS. Donald Trump would just as soon not talk about coronavirus. And in fact, he's doing whatever he can to talk about everything else with his tweets, with his contempt for the scientists who served on his panels. in some ways willing stooges to his show, his carnival shows. Excuse my little bit of hyperbole there, but it is distressing to see some of the best scientists in the United States used as props instead of being used as effective public health actors.
Well, so I think hopefully there's some wisdom, some lessons to be learned from any comparisons that could be made between the Reagan administration's response to HIV and the Trump administration's ongoing response to coronavirus. Eventually there was enough political capital and will within the public and the scientific community. Everyone kind of came together and has had all this great success finding ways to prevent and treat HIV/AIDS. And so what should the public health community be doing?
A massive amount of activism by people inside and outside of the public health community to have that happen. And I'm that brings us back to the work that we're doing here in New Haven and statewide with our harm reduction working group right now to try to draw attention to all the areas where the government response has been deficient. Some of the response has been quite good, and that shows some progress between the 1980s and the 2010s. Thank goodness for that. Thank goodness we've learned some lessons. Thank goodness that we've created communities of activists and public health people who leapt at the opportunity to do something, to create guidebooks, to create fact sheets, to work with people in the community to bring them up to speed so that they would understand the need to take care of themselves, in the face of this new threat to their health. They're already experiencing lots of threats to their health if their substance use is problematic. Some of those problems, are obviously the infectious disease complications, whether it's HIV or hepatitis C or abscesses or systemic septic diseases like endocarditis and fungal infections that plague people who use drugs. But I think that the other issue is that the criminal justice system still treats people who use drugs as law breakers and not people with a treatable disorder or disease. At the very same, and our history on this is schizophrenic, if you will. At the very same time, 100 plus years ago in the 1910s, that we started to develop our system of criminalizing drug use, starting with the Harrison Narcotics Act and the Supreme Court rulings in its wake. We also, the U.S. public health system also ruled that addiction was a disease. And so we've had these parallel approaches, contradictory approaches for at least a century now. And I see as one of my jobs as a public health actor and researcher is to remind people that the overwhelming evidence is that the criminal justice approach has made the problems worse rather than better. And that a public health approach that recognizes that individuals with substance use disorders have human and civil rights that shouldn't be violated, should not be treated like criminals, is supported by the weight of evidence.
Yeah. Do you feel? I have one more question, and to remind anyone who's watching that if you'd like to leave a question in the comments, we'll do our best to address it. do you feel any notes of optimism for the activism that's happening in the moment with regard to criminal justice reform? And have you seen any measures being taken around the country that you think are meaningful?
I'm thrilled that the Black Lives Matter, the protest movements in the wake of George Floyd's death are having some effect on talking about reforms. But the reforms we're talking about are at this point quite superficial. We're talking about reforming the soldiers who enact the racist policies that are embedded in the United States criminal and legal systems. We need much more fundamental overhaul of, and maybe even some sort of recognition of the need for reparations to correct the wrongs that have disenfranchised and impoverished, incarcerated and brutalized minority populations in this country ever since our founding fathers, and even of course before that, since slavery predates the founding of the United States, ever since we started a system in which we allowed human beings to be treated as properly based on the color of their skin.
Right. When you talk about fundamental reform, to me, the widespread uptake of at least awareness of notions like defunding or abolishing police is a step toward that radical systemic reform you describe. And in Minneapolis, they took a vote pledging to do something like that. Do you think that will come to pass, or is there some political
there are plenty of political barriers. I think the one thing we have to understand is that 95% of police work does not require a police force. Currently, much of what they do is social work, mental health issues, drug-related stuff, none of which should be the province of the criminal justice policing system in this country.
Right.
And if we can take those roles, those jobs, away from people who are trained to react first as warriors and second as public servants, or care providers, or protectors, the better off we'll be. That won't deal with the underlying issue that many police instinctively see people, especially Black and Hispanic males, as intrinsic threats to their own safety. I don't know how we're going to change that, but until we change that, until we empower local communities to resist policing as the primary form of what would you call it? Societal, I don't want to use the word control, stability. That means we're going to have to deal with improving education, improving home ownership, or at least improving access to capital, improving there's a difference in Black and non-African American communities, in not just in terms of the amount of income they earn, even if you account for job differences, but when you look, African American and Hispanic communities doing this, people doing the same jobs are paid less than their white counterparts. But even more than that, the amount of wealth that people have, their ability to withstand economic hardships in times like a coronavirus epidemic, where they're going to have to not work for a while, where they're going to see their savings compromised, whittled away because they're not working or because they're working part-time, or they're getting sick.
Right.
We have to make adjustments for this historic disparity and find ways to remedy that.
Right. Right. Um, there are so many issues that come together here. If I could end on a note of um, hope or at least possibility, it's that there are so many issues that everyone's area of expertise in public health and outside of public health, there's work to be done here. From people who are in law, in government, in basic science, in medicine, in all areas. This is a problem that affects every part of society, and people have expertise and who may be finding themselves stuck at home right now and not sure how to help make the world a better place. Thinking of things in this aggregate way can help hopefully remind everyone you have something to contribute, and work is needed.
And one last comment that dates back to the anti-war movements and the civil rights movements of the couple generations past is to think globally but act locally. We have plenty of work to do here.
Yeah. Thank you so much for all the time. I really appreciate it, and wish you the best of luck in your continued work.
Well, thank you very much.
All right. Thank you, everyone, for watching. We'll see you next week.